Welcome to the fourth webinar in our fall series. I'm excited to introduce today's webinar called Open Mic, Ask the Doctors and the Dietitian, hosted by the National Celiac Association and the Celiac Research Program at Harvard Medical School. I'm Lee Graham, Executive Director of the National Celiac Association, serving the gluten-free community since 1993. I want to take this moment to thank all of you who have donated to our food insecurity initiative, Feeding Gluten-Free. Food insecurity in the celiac community is a serious problem in our country. With your help, NCA has donated $950,000 worth of gluten-free food to food pantries in 49 states. From the bottom of my heart, many, many thanks to each and every one of you. Together, we have accomplished so much. For today, you are welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your Zoom screen. If you are still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org or by phone 857-282-6470. Also, this session is being recorded and will be available for viewing on NCA's website, nationalceliac.org. I'm honored today to introduce our moderator, Dr. Mark Salvatore. Dr. Salvatore has been a practicing pediatric gastroenterologist at Massachusetts General Hospital for Children since 2006, with specialized expertise in celiac disease and mind-body medicine. Dr. Salvatore is the founder of the Pediatric Mind-Body Medicine Program at MGH, the first of its kind in the nation, and has been its clinical director since 2018. He's a Benson Henry Institute certified healthcare practitioner who provides mind-body consultations for children with difficult to treat gastroenterological disorders, particularly those of a functional nature. He has been seeing pediatric patients as an active member of the Celiac Center for Celiac Research and Treatment at Harvard Medical School since 2014. Welcome, Dr. Salvatore.
Thank you so much. And so now I'd like to introduce our three speakers. First is Dr. Denis Chang, who is a pediatric gastroenterologist in the Division of Gastroenterology and Nutrition at Boston Children's Hospital. He completed his pediatric residency and chief residency at NYU School of Medicine, followed by his fellowship in gastroenterology at Boston Children's Hospital, where he stayed on as faculty after his fellowship. His clinical focus includes caring for children with celiac disease, and as a member of the Celiac Disease Program, he is also involved in several ongoing clinical research projects. His favorite part of his job is being a part of the multidisciplinary team where he can collaborate with and work alongside expert dietitians and social workers, while also partnering with patients and family members to treat children with various gastrointestinal conditions. Our second speaker is Dr. Rupa Mukherjee. She is an associate professor of medicine at Harvard Medical School and an attending gastroenterologist at Beth Israel Deaconess Medical Center in Boston, Massachusetts. She sees patients with celiac disease and non-celiac gluten sensitivity at the Celiac Center in addition to seeing general gastroenterological patients. She also performs procedures including endoscopies and colonoscopies. Dr. Mukherjee received her medical degree from Johns Hopkins University School of Medicine in Baltimore, Maryland, and completed a clinical fellowship in gastroenterology at Columbia University Medical Center, an advanced fellowship in celiac disease at Beth Israel Deaconess Medical Center. Dr. Mukherjee is involved with various research projects through the Celiac Center. In her spare time, she loves cooking, traveling, and spending time with family and friends. And last but not least is Pam Cureton. She's a clinical and research dietitian specializing in the treatment of gluten-related disorders. She has worked in the area of gluten-related disorders since 1993. When she joined the University of Maryland School of Medicine. Her current position includes working at the Center for Celiac Research and Treatment at MassGeneral Hospital for Children and the University of Maryland Celiac Program. Her work includes coordinating the clinical management of patients with gluten-related disorders educational programs, and lectures for the celiac community, physicians, dietitians, and other health care providers, and involvement in research projects. She's the author of many articles on celiac disease and the gluten-free diet, including textbooks, journals, and patient education resources. Please welcome them all. And we will now begin. So the first question is for Dr. Chang. My daughter is 12 and tested positive for the antibodies for celiac disease. She has an appointment with a gastroenterologist in January. She's feeling so much better on a gluten-free diet. Does she need to reintroduce gluten back into her diet? And if so, for how long and how much?
Thanks so much, Dr. Salvatore, for the introduction. And I'd like to just take some time to thank Lee and the NCA for having me along with the other panelists, along with all the people who submitted great questions for today's webinar. And so hopefully we'll have a lively discussion. But this is a great question and a very important one, just because right now the way that we diagnose celiac disease is through an intestinal small bowel biopsy that we do during an endoscopy. And what we're actually looking for in making the diagnosis of celiac disease is we're looking for changes in the intestines in individuals with celiac disease when they're consuming gluten. And so, next slide. And so right now, while we do know that it's important to be on a gluten-containing diet when going through testing for celiac disease, in terms of how much and also how long you need to be consuming gluten, that's really an open-ended question. And so right now, there's no standard guideline in terms of how it is that we reintroduce in individuals who've been eliminating gluten prior to testing for celiac disease. And a lot of the information that we're learning for has really come out from what we call gluten challenge studies, and predominantly in the adults. There really aren't any gluten challenge studies that's currently being performed in children. And what we're really finding from these studies is that there is a wide variability in both not only the dose of gluten and also the duration in individuals who have celiac disease, who've been on a gluten-free diet, prior to finding some of these intestinal findings that really, is consistent with the diagnosis of celiac disease. And so I was able to find one systematic review that's almost a decade old, where they actually looked back at the different types of gluten challenges up to that point. And the conclusion that the author came to in looking at this data was that a 3-month, quote unquote, high dose gluten challenge may identify most celiac patients. However, really, there's nothing that's standardized. And so, some of the things that I think about when a family comes to me with a certain circumstance are different factors, and that includes one, symptoms and possibility of celiac disease. Secondly, the blood markers, the serology, as we often call it, the autoantibodies, because we know that the higher they is, the more likely we think about celiac disease. As opposed to the lower or mildly elevated ones, which there may be false positives. And so we really look towards the biopsy to make the diagnosis, and also the duration that the individual has been on a gluten-free diet. And so one example I would give is, if I have a patient who had very high serology, symptoms that's very suspicious for celiac disease, and they had eliminated gluten for just a week before I saw them, they may not need to be back on gluten for too long before we can do the endoscopy. Whereas if there was another patient who had very mildly elevated blood tests when they were tested for and tested positive, but they were on a gluten-free diet for 2 to 3 months, then in those cases, I may recommend being on a gluten-containing diet for longer than a few weeks. Usually I think about 6 to 8 weeks to start before undergoing some of the more objective testing to really see if they have celiac disease. And then finally, from these gluten challenge studies, we're learning a lot about celiac disease, which is really exciting. And hopefully in the future, we'll have other biomarkers or ways that we can make the diagnosis. But right now, it's important to be on a gluten-containing diet prior to undergoing the endoscopy. And so I often recommend individuals just to go back on an unrestricted gluten-containing diet before we think about the timing of when to do these more definitive tests.
Thank you, Dr. Chang. Next slide. Is there a relationship between celiac disease and mouth sores?
Another great question. And so I'll definitely get to this specific question, but just want to open it up to, I guess, the broader question that this individual may be asking is, what are the symptoms associated with celiac disease? And so next slide. And so I like to think about celiac disease as, even though it's primarily a gastrointestinal autoimmune condition, it can really affect all different parts of the body. And so next slide. The first thing that we think about are, do you have any gastrointestinal symptoms? And they can be a lot of different ones. And they can be either abdominal pain. Some people present with diarrhea, while others, their presenting symptom may be constipation, bloating, and flatulence or gasiness is another common symptom, nausea and vomiting. And in kids especially, we think about alterations in growth, poor growth, or weight loss, which can all be signs of celiac disease. Next slide. But we also know that there may be symptoms outside of the GI tract that people can present with celiac disease. And here, this is definitely by no means all-inclusive list, but these are some of the different types of symptoms or signs that people can present with that could indicate celiac disease. And in this specific question, definitely we can see mouth sores being a presenting sign of celiac disease. And so, but we also, the other thing I like to point out here is that there's a lot of other things that can also explain many of these symptoms. And so it may not necessarily be celiac disease. And the one example I think about are people who are undergoing evaluation for their different symptoms. And sometimes we find celiac disease, but their symptoms never go away. And so the things I think about in that case may be that, maybe we found celiac disease almost incidentally while we were undergoing evaluation, but now that we find it, we want to treat it because we know it causes inflammation of the intestines. And so it's just really trying to peel back the layers in terms of how it is that we can get, kiddos and adults with celiac disease on the right track for success moving forward. Next slide. So again, in terms of mouth sores and celiac disease, there definitely is an association. And we do find that in people who have celiac disease compared to those without, we do see a greater chance or occurrence of mouth sores. As far as why is it occurring, that's a little bit hard to answer. It's either one, because of the direct inflammation related to gluten, but also we know that since the small intestine is the organ that's responsible for absorbing a lot of the nutrients, nutritional deficiencies can definitely lead to mouth sores too. And so, there are different reasons why the mouth sores can be there to begin with. But if it's related to celiac disease, then really the treatment, which is a strict gluten-free diet, should heal up the mouth sores. However, this is something I'll probably point out later on in my session as well. But, if the symptoms are persistent, I like to think of it as an open-ended evaluation because the symptoms may not have been a presenting sign. And so even if, despite being on a gluten-free diet, symptoms are persisting, keeping it in mind in terms of the other conditions that could lead to those symptoms. Next slide.
Yeah, I also think you bring up a good point that a substantial minority of patients don't have any symptoms, or at least don't recognize what they have are symptoms, right? And so a lot of people won't realize how unwell they felt until they've been on a gluten-free diet. So
yeah, and that's exactly it. And sometimes I'll see that, especially in those individuals who are at higher risk, for example, like first-degree relatives, people with other autoimmune conditions where we're screening for celiac disease and they have no symptoms. But once we find it and treat it, they're like, wow, this really was a big difference. So in retrospect, maybe they were actually having symptoms, but they didn't realize it up until that point.
Exactly. All right, next question is there a standard guideline for follow-up after diagnosis, such as blood work and other screenings? Is there a difference in follow-up between children and adults?
Another great question. So next slide. So if you look at right now, all of the large national society guidelines, and that includes in adults, the American Gastroenterological Association, the American College of Gastroenterology, and in pediatrics, the North American Society of Pediatric Gastroenterologists, Hepatologists, and Nutritionists, they all wholeheartedly do recommend ongoing follow-up following a diagnosis of celiac disease. And some of the things the reasons why is, one, celiac disease is a chronic or lifelong condition. So it's important to make sure that, one, if symptoms are there to begin with, that symptoms gradually improve or resolve. And if not, figuring out why it is that symptoms may be ongoing. Secondly, we know that, the gluten-free diet may be a lot easier said than done. And so these are the times when I like to sort of check in, not only with myself, but also with the dietitian that the individual is being cared for with, to see how the gluten-free diet's going along. And especially as, you know, someone who takes care of kids, and a lot of my conversations are really with the parents, especially in younger kids, it's an opportunity for me to tell them as their provider and as their physician, you know, why it is that's important to be on a gluten-free diet and what the benefits are, and to help them understand from my lens, you know, why it is that they may not be able to eat the birthday cake that everyone else is eating at that time. But we also want to make sure that good equivalent or equitable options are there so that they can still partake in all the things that they want to be doing. It's just that they just need to be gluten-free. And then in kids, again, we see growth failure or weight loss or poor linear growth as a common presenting factor. And so we do want to make sure that the catch-up growth is there and that they're heading on the right track, especially once they're on a gluten-free diet. In terms of the testing and screening, that's a little bit less clear. And so, you know, a lot of the guidelines do recommend checking the celiac serology and making sure that they normalize. But what we do know with these celiac markers is that they're really good for the diagnosis and screening and picking up celiac disease. But in terms of reflecting what's going on in the body, the progression, especially the improvement once you're on a gluten-free diet, it's not as great of a marker, though we do anticipate that over time, once you eliminate gluten, these should normalize. And so we do use that along with symptoms, along with these other things to sort of monitor symptoms and growth moving forward. I think the key point here is that it's not just a physician or it's just not just one provider. It's really a multidisciplinary team. And again, that's one of the things I love about working with the celiac program here and along with other collaborators everywhere else, because we get to really work together as a team. And the analogy I like to explain to families and patients is that, you know, we're sort of joining your family to sort of go on this journey together. And so next slide. So just to give an example of what we recommend here at Boston Children's after we make a diagnosis of celiac disease, is the first thing is getting someone and their family members on the right track on getting on a gluten-free diet. And so, you know, usually we do offer a couple of times a month a group class, all based via Zoom or online, where people can learn from one of our expert dietitians about what the gluten-free diet means, how it is to be gluten-free, what are the things to look out for. And then after that, I always think that having a dietitian as part of your care team is very integral, especially as we know that the gluten-free diet may lack in certain micronutrients compared to a gluten-containing diet. And every circumstance is different. Every household is different. So we really want to tailor that experience to own individual family members. And so I do recommend a dietitian follow-up 1 to 2 months thereafter, and then as needed or as appropriate, because every circumstance is different. And I do recommend, you know, every 2 to 3 month follow-up. And then over time, we sort of expand it out to about an annual follow-up each year, where I do check celiac markers, making sure that they normalize. Also screening for autoimmune thyroid disease, which, you know, we can see after a diagnosis of celiac disease, along with any other questions and things that come up.
You did an excellent job of proving why it's upsetting when I get patients that have come to me and they were told by their doctor that, you know, based on a blood test, they have celiac disease, go gluten-free and you're fine. It's very, very upsetting because that's the absolute wrong way to manage these patients. So excellent summary there. All right. My 11-year-old was diagnosed with celiac disease in April. From birth, she has rarely exhibited hunger and is quickly satiated, means full quickly. We hope that the gluten-free diet would help her appetite. However, while her antibodies normalized, her weight gain remains a problem. Does having celiac disease interfere with appetite regulation?
Oh, great question. So next slide. So right now, there doesn't seem to be a direct link between the two. But again, if you think about the whole host of different symptoms people can experience, a lot of it can definitely affect appetite. And so again, you know, I think I've touched upon a lot of these points in my earlier slides, but really in terms of what symptoms are associated with celiac disease, sometimes we don't know until after you're started on a gluten-free diet and as things improve. You know, and then I like to use that analogy again as layers. We like to sort of peel back the layers and sort of get into the core of, you know, why it is that people are having symptoms and how it is that we can best address it. And again, two quick studies that I have here. One that comes out from our group here at Children's, where we had kiddos who, despite being on a gluten-free diet for 6 months, still had symptoms. And the most common reason why was ongoing gluten ingestion. But if you look at this, a list here, other conditions, for example, constipation, we often can see after someone started on a gluten-free diet because you start to decrease your dietary fiber as you're eliminating gluten-containing grains. And so there are other reasons why symptoms may be persisting, even though you're still doing the right thing in terms of eliminating gluten. And there was one study here that was done out of Europe, where they looked at adults who were adherent to a gluten-free diet, and a little more than half of them actually had other conditions that can explain their symptoms. And so it's always about reassessing how it is that we can help symptoms and really tying back, is this due to celiac disease or not?
How long does it take for GI symptoms to go away and for celiac antibody levels to normalize after starting a gluten-free diet? Is it different for kids and adults? I just saw this question in the Q&A, so you're ahead of the game.
Awesome. Super important question. One that I commonly get asked.
5 minutes, Dr.
clinic.
Chang, 5 minutes.
Excellent. Thanks, Melinda. So next slide. So I think this graphic sort of sums it up in that a majority of symptoms, this is the graph on the left is in children, the graph on the right is in adults. It's a single center study. But for the most part, a lot of the gastrointestinal symptoms do improve. It seems like, at least in this group's experience, it improves a little bit quicker, or in the majority of children, where some adults may still have lingering symptoms. And so I know that Dr. Mukherjee is going to talk about this later on in today's session. But it takes time. If you look at the x-axis here, a lot of symptoms get better within a year, but sometimes it can take longer than that. And so this is where follow-up is really key. And next slide. And this is a pictograph of another center where they looked at celiac autoantibodies. And the blue line are those who, blue and the orange are those who had higher, so greater than 10 times the upper limit of normal range, compared to those who are less than that, which is the gray bar. And again, same thing goes for serology. It takes time, but they do eventually normalize. But in terms of an exact timeline, I don't think of it in terms of timeline. I think of it as general trends. And so if, the times when I sort of wonder about ongoing gluten ingestion or what could be going on is if it doesn't work in this downward trend, or if there's a change in direction and it goes from a downward trend to an upward trend. Those are the opportunities where we have our kiddos revisit and meet up with the dietitian to really look closely at their diets to see if there's maybe hidden or unintentional sources of gluten, even though they may not be having symptoms. Next slide.
I think it's also important to note that there is a certain percentage of at least kids that I've seen whose markers never return to normal. And as long as you've proven that their celiac is in remission through pathology, it's not as much of a concern. It's not a concern. So I think you would agree with that, correct, Dr. Chang?
Absolutely. And those are the times when maybe a follow-up endoscopy could be helpful to really see what's going on, because these markers are not always reflective of what's actually going on in the intestines.
Exactly. I tell families it's sometimes okay if the markers don't go back to normal, as long as we prove that the celiac is in remission through biopsy. So my daughter was recently diagnosed with celiac disease at 4.5 years of age. I know having an autoimmune disease raises the chances of getting another. What percentage of individuals with celiac disease later go on to develop another autoimmune disease?
Awesome question. And I'm actually going to leave this pretty short, just because a couple of months back, Dr. Ed Liu from Children's Colorado actually came in and gave a great talk as part of the NCA webinar series about autoimmunity and celiac disease. But next slide. But we do know that, autoimmune conditions can go hand in hand. And so by all means, this is not a full exhaustive list, but the two most common ones that we see closely linked with celiac disease is going to be autoimmune thyroid disease and type 1 diabetes. And after a diagnosis of celiac disease, the autoimmune condition that we see at individuals at greatest risk for is going to be autoimmune thyroid disease. And so again, as part of my, follow-up screening labs, I do often check thyroid labs either every year or every 2 years to see if, even if they're not having symptoms, if they're at risk or maybe in the process of developing an autoimmune thyroid disease. And in that case, I would refer over to an endocrinologist.
Oh, excellent. Thank you, Dr. Chang. Now we're going to move on to Dr. Mukherjee. How come I don't feel totally better on a gluten-free diet? Is it possible that there are additional foods I need to eliminate from my diet?
Thank you, Mark, and thank you to the NCA and to Lee Graham for having us and organizing today's webinar. We've got a bunch of wonderful questions, and it was hard to choose, so here are a few of them. Next slide. So this is a very commonly encountered problem in my clinic, and really there could be quite a few reasons for why this is happening. Not feeling better despite being strictly gluten-free. So one of the most important things, as Dr. Chang mentioned in a couple of his questions, is ruling out unintentional gluten exposures, cross-contamination. We know that even trace amounts of gluten can be the reason for ongoing symptoms. So that's important to do. Also important to remember that maybe it's not a food-related issue, but something else. There are various conditions that can be associated with celiac disease, and some of the top ones are irritable bowel syndrome, IBS, that can develop down the road. You need to also consider small intestinal bacterial overgrowth, or SIBO, testing for that. Microscopic colitis, another potential associated condition that's causing ongoing symptoms despite being gluten-free. And then other conditions to consider would include peptic ulcer disease, gastroesophageal reflux disease, gastroparesis. This is a list that came from a study that was done by Dr. Leffler and our group looking at causes for ongoing symptoms in patients who are strictly gluten-free. So these are the top contenders. Next slide, please. So is it possible that there are additional foods I need to eliminate from my diet? And the answer, or my opinion, is yes. So despite being gluten-free and still not feeling well, one needs to consider, could there be a lactose intolerance issue? Another potential cause for ongoing symptoms would be a fructose intolerance, or intolerance to fructose and its variants, or FODMAPs. And I'm sure a lot of the participants here have heard about this term, FODMAPs, or low FODMAPs. So the word FODMAPs stands for fermentable oligo-di-monosaccharides and polyols. And it refers to short-chain carbohydrates that are naturally present in various food products, but that can be poorly absorbed in the small intestine in some patients. And the end result of that can be bloating, gas, and diarrhea. So despite being gluten-free, it's possible the patient has a fructose intolerance problem that could be the reason for ongoing symptoms. And this would be a discussion for them to have with their gastroenterologist and or dietitian. Sort of more secondary level or a tier of investigation would be, could the reason for ongoing symptoms be soy intolerance, possibly a problem with corn? I've also had a few patients in whom the issue actually ended up being a histamine-related problem. So after evaluating their diet, we looked for histamine-rich foods. It's a pretty long list, but a lot of these foods are fermented foods, and alcohol is on the list too. And then there needs to be consideration for a possible food allergy as a reason why a patient has ongoing symptoms, despite being gluten-free. And at that point, with discussion with their physician, they might want to see an allergist. Next slide.
All right. Thank you. Excellent answer. For adults with celiac who are on a strict gluten-free diet but still having diarrhea, what would you recommend?
Yeah. Okay. Great question. This too comes up a lot. Next slide, please. So after ruling out gluten exposure, which is really important to do, the next level of thinking would be, could the diarrhea be due to an infectious or inflammatory condition? So at this point, I will typically send a stool sample for various tests, including for culture, looking for what are called ova and parasites, and potentially, given the patient's history, for infectious etiology called C. difficile, particularly if the patient has been on antibiotics recently. There are a few blood tests that can be performed to further investigate the cause for the ongoing diarrhea. Those could be some inflammatory markers. And then in addition, there is a link between hyperthyroidism as one of those associated conditions in celiac disease, and that condition could be a reason for diarrhea. despite a patient being gluten-free. So I often might check thyroid studies in that case. Need to also consider other food intolerances, as I referred to in my previous slides, that could be a source of diarrhea, such as lactose intolerance, fructose intolerance. Another common cause for diarrhea in patients with celiac is SIBO, or small intestinal bacterial overgrowth. And symptomatology here, in addition to loose stools or diarrhea, can be a lot of bloating, belching, maybe abdominal distension, and malodorous gas. So in the appropriate patient, that would be something to think about. And then finally, there is a link between celiac disease and some pancreatic issues. So potentially the reason for the diarrhea is the patient has some exocrine pancreatic insufficiency. So at that point, I might want to check a stool sample for a test called an elastase level that gives me an indication if there's insufficiency or not. Next slide. It's also critically important to take a thorough medication history, because very often the reason for the diarrhea could be medication induced. So important to take a look at all the medications that a patient is on, any that were newly prescribed, and even those that have been on the list for a while, and see if there's any correlation. And there's certainly a role for endoscopic evaluation, assuming that other studies have been done. And those could be, one, important to check the celiac disease status. For example, is the reason the patient has diarrhea or having malabsorption due to some ongoing villus atrophy? And so having that baseline endoscopy is important in that you can compare the two. Also, because there can be overlap between celiac and inflammatory bowel disease, Crohn's and ulcerative colitis, at this point, colonoscopy might be a test that the patient, along with their physician or gastroenterologist, choose to pursue. And then in patients with celiac, there can be manifestations in the colon, a condition called microscopic colitis, lymphocytic colitis, or collagenous colitis. This condition can be your cause for ongoing diarrhea, and the way that diagnosis is made is through biopsies of the colon. So all of the above would be important to consider if a patient has ongoing diarrhea despite being gluten-free. Next slide.
Thank you. Thank you. So that reminds me of two things. I've had at least a few patients whose markers came back positive or had symptoms, and we ended up finding out they had started a multivitamin, or even I think one person was on Pepsid or something.
Wow.
And we ended up finding out that they had gluten in it. So reviewing your medications for gluten contamination is an important thing to do. And then secondly, we had a question, and it kind of relates to that, and I can even answer, is how much damage does a single exposure to gluten do to your body? Do you start completely over the healing process to the parts of the body through the single exposure as damage? And I'm happy to answer that. Like, we don't know exactly the amount of damage that occurs. I probably wouldn't even use that word. We don't think that it takes multiple exposures along a period of time to create mucosal damage. So we don't know exactly how much contamination you can have without triggering the whole process to have mucosal damage. But I tell all my patients a single exposure may give you symptoms, and some patients it doesn't even give them any symptoms, but it's not going to start the whole process back over. You're not going back to square one. And so a lot of times patients need to hear that, because they'll be very upset that they've been contaminated. I
agree with you, Mark. I really don't have much else to add there. It's low level, sort of unintentional continued exposure to gluten is what we're most concerned about. Even like 1/100th of a piece of bread, but frequent exposure to that can cause continued inflammation of the small intestine, versus a one-time exposure of eating pizza by accident that someone thought was gluten-free.
Yes. Yes, and you're way more likely to have symptoms from a larger exposure than very, very small exposures that could sort of trigger the inflammatory process. Yeah. So next question. What are the proper blood tests to run to diagnose celiac disease? Do you need a, quote, full celiac panel, or is the TTG IgA and the total IgA sufficient?
Next slide. Great question. I think we talked a little bit about serologic studies in Dr. Chang's slides too, but good to review this again. So the IgA, anti-tissue transglutaminase, or TTG, is the preferred antibody test to screen for celiac disease. And there have been a number of studies to look at how sensitive and specific this test is. And so I'll define what I mean when I say that. So sensitivity and specificity, specifically sensitivity, refers to the fact that the result is a true positive. What that means is the patient has the disease, has celiac disease, and the blood test is positive. In this case, the IgA TTG has a sensitivity of over 95%, which is excellent. Specificity refers to a true negative. So in this case, a patient does not have the disease process, and in addition, the test comes back negative, confirming that fact. So the IgA TTG test has both a sensitivity and a specificity as a function of greater than 95%. So it's a great start. Now, we know based on some studies that up to 8% of patients in the celiac population can have what we call IgA deficiency, or low antibody A production. And because this TTG is based on the antibody A level, should also check total antibody A level along with the TTG. Next slide. There is an alternative approach, though, which myself and other practitioners in certain cases will follow, and that is referring to this question of a full, quote unquote, full celiac panel. And that involves including the IgA test and an IgG, or antibody G-based testing, with the IgA TTG and an IgG DGP, or deaminated gliadin peptide, in patients who have a high probability of celiac disease. So these would be patients who have first-degree family members with celiac disease, and or patients who have symptoms that are highly suggestive or concerning for celiac disease. Those cases might want to combine the two. And a very important point to emphasize is that we recommend that diagnostic antibody testing ideally should be performed on a gluten-containing diet. Next slide.
Thank you. So what labs are best to monitor gluten-free diet adherence, antibodies, and condition of the small intestine?
Next slide. So thank you for this question. I think Dr. Chang referred to it a little bit on the pediatric end. So from an adult perspective, as Dr. Chang had mentioned, it's really important that in a patient's history and assessing their celiac antibody levels, combination of the two is really important in assessing adherence to the gluten-free diet. So in this case, as I mentioned previously, the IgA TTG or the IgA IgG deaminated gliadin peptide antibodies would be important to check to assess for adherence. Typically, I check the antibodies every 3 months when they're elevated until they normalize. And then at that point, often I like to check them yearly. In some cases, at the point they've normalized, I might check in 6 months and then yearly. In terms of additional tests, lab tests that I check to assess adherence, those would include vitamins and minerals that can be malabsorbed in the small intestine due to inflammation. So a typical panel would be vitamin D, iron studies, certain B vitamins, zinc, along with the celiac antibodies. Next slide. In terms of assessing the quote unquote health of the small intestine, there's no standard biomarker or lab tests to assess the degree of inflammation and or villus atrophy. In some regards, the celiac antibody level in other labs are used as a rough proxy for assessing the small intestinal health. And as Dr. Chang had mentioned, the correlation isn't always great, but it is the marker that we have. And that's why also the history becomes very important too. Repeat endoscopy with intestinal biopsies is recommended in cases with where there is a lack of clinical response to the gluten-free diet, or cases in which the patient was doing well, but then have a relapse in their symptoms despite being on a gluten-free diet. So one would want to assess the health of the small intestine if there's ongoing atrophy or a condition that we call refractory celiac disease. The next point that I'm about to mention comes up all the time. As of now, at least in the adult world, there's no guideline for routine just surveillance endoscopies. So if someone has a diagnosis of celiac disease and they're doing well, there's no need to necessarily every certain number of years or intervals do an endoscopy to check the celiac disease status. Next slide.
Rupa, I just want to jump in for a second. Those couple slides made me reminded me of the analogy that Dr. Fasano uses, which I've lifted from him, is that celiac disease is not a biopsy and celiac disease is not a blood test. It's a story, right? And there's a beginning, there's a middle, and there's an end. And that always helps, people understand that it's a combination of factors, symptoms, signs, blood work, biopsy, gluten restriction, response to gluten restriction, blood work, follow-up blood work. And so I always tell people this is a story that we put together, and by the end we'll have a clear answer. Sometimes it's immediate in the first chapter, but sometimes it takes a couple chapters to get to the story. So that usually relieves a lot of people's anxieties.
Yeah.
All right. Can someone be gluten intolerant but not have celiac disease?
Excellent question, and brings up a huge topic. So next slide. And I'm glad someone asked this question. So yes, someone can be gluten intolerant, not have celiac disease. And this is a good segue into very briefly starting a discussion on distinguishing celiac disease from gluten intolerance, or another term we use for that, non-celiac gluten sensitivity, NCGS. So definitions probably are important here at this point. Celiac disease is defined as a chronic immune-mediated inflammatory disease of the small intestine triggered by exposure to dietary gluten in genetically predisposed individuals. Next slide, please.
And 5 minutes, Dr. Mukherjee, 5 minutes.
Celiac disease is characterized by the production of autoantibodies, such as the TPG antibody, the endomysial or EMA antibody, and the deaminated gliadin peptide. In addition, on biopsy, there's certain key or hallmark histologic finding. And in front of you are some representative slides. So the panel on the left shows the intestinal villi, and they're long and elongated. And that's what we like to see in healthy villi. With repeated exposure to gluten, we see the panel on the right. In here, those long elongated villi are very stubby. And this is the term for villus atrophy. They're atrophied or stubby. There's also a lot of cells there, the little purple dots, and these are the lymphocytes. And there's also an excess of these crypts that we see. So these histologic findings are hallmark for celiac. Next slide. Whereas non-celiac gluten sensitivity is defined as a non-allergic, non-autoimmune condition in which gluten consumption can lead to symptoms very similar to those seen in celiac disease, and gluten withdrawal leads to resolution of symptoms. In contrast to celiac disease, in NCGS, there's an absence of autoantibody production and an absence of small intestinal inflammation like we saw on the slides before. Next slide. So it is important to distinguish NCGS from celiac disease, since celiac can lead to nutritional deficiencies, risk for complications such as bone loss, anemia, fertility issues, cancer risk. There are implications for family members at risk for celiac disease and developing associated conditions as well. So the degree and duration of adherence to the gluten-free diet might vary in patients with NCGS compared to patients who have celiac disease. Next slide. We know that in the case of celiac disease, strict lifelong adherence is recommended, whereas for NCGS, an individual might try to liberalize their diet and see if they can tolerate small amounts of gluten pending symptoms. Next slide.
And, oh, sorry, Dr. Mukherjee, I just want to add, and you did say this, and I just want to reiterate it. We do not have a validated biomarker for gluten intolerance. And often we have patients come to us with IgG testing, perhaps sent by a naturopath or someone else, and they're saying that, you know, I have gluten intolerance. And we don't have a validated biomarker just yet. Someday we will, I would imagine, but we don't. So I just think that just bears repeating again. to all the participants listening. Last question in the last couple of minutes. Is gluten bad for everyone to eat?
Great question. Next slide. This is really the subject of hot debate with lots of media buzz over the past few years. Various notable personalities in the media have supported going gluten-free for their own personal reasons. So this question comes up a lot. Next slide. I find this hard to believe, but study after study that I have read has shown or described that an estimated 25 to 30% of the US population, nearly a third, have reduced their gluten intake or cut it out entirely. That's pretty astounding. And there are various reasons for that. One of which is there's a rise in popularity of other diets, such as the low-carb diet, the keto diet, paleo diets. And there are valid health concerns regarding gluten and the role of inflammation, the concept of a leaky gut, and this idea of autoimmunity. Next slide. But what we do know is gluten-containing whole grains are a valuable source of fiber, B vitamins, and minerals. And so going gluten-free without proper nutritional guidance could potentially lead to deficiencies in important nutrients, vitamins, and minerals. We also know that processed gluten-free food is often higher in fat, sugar and calories, and lower in fiber, and that can lead to weight gain, constipation, and other health issues. Next slide. So in general, dietitians and the ones that I work with recommend liberalizing one's diet such that it is well balanced whenever possible. And so that might include doing a trial with gluten and seeing if one can tolerate it or not. It goes without saying that any major sort of dietary change that one is thinking about doing, please discuss that with your physician and or dietitian, just to make sure you're on track and getting your appropriate nutrients and vitamins and minerals.
All right, thank you so much. Next is Pam Cureton. This is your question. My 8-year-old daughter was recently diagnosed with celiac disease. So trying to navigate the items that are not clear-cut, per the GF scanner app. They say no gluten ingredients, but the manufacturer doesn't mention about cross-contamination or contact. The things that are confusing me are cheeses and things like canned vegetables with no seasonings, etc. Per the labels, they don't appear to have gluten, but then I see that on the app, so I'm not sure what to do. From the information I've received from my doctor, things like canned vegetables and dairy should be okay. But then the information that the scanner app notes means I'm not sure about cross-contamination. Help me, Pam.
I would love to help with that. So next slide, please. This is so common. This is usually where I always start when I talk with patients, whether they're newly diagnosed or they've been diagnosed for 10 years. Reading labels can be very confusing. Oftentimes people don't buy a safe product because they're just confused. So they go into the store, they only buy things that are labeled gluten-free, making an expensive diet already more expensive. So it is confusing. So I would like to make it very easy for you to maneuver through purchasing foods that are safe. And we can give a big thank you to FALPA, the Food Allergy Labeling Consumer Protection Act, that was enacted in 2004. That if any of the top 8 allergens, wheat being one of them, are used in any way, shape, or form intentionally, they are listed in plain English on that label. So the 2 examples would be in parentheses next to the ingredient or under that contains statement. So capital C, contains. So that's the first place we always want to start to look for if wheat is being used in a product. So this has been very helpful to kind of get some of the major ingredients to look for if they have a gluten-containing ingredient. So the next slide. Now, I'm very proud of Dr. Salvatore because he has learned that there are 6 words on a food label to look for. And when I'm not available, he is very good at instructing patients. So if a product is labeled gluten-free, then it would be a good idea just to review the label, just to make sure that there's no misbranding or any mistakes being made. But manufacturers are really very good about making sure that the product labeled gluten-free meets the FDA standards of less than 20 parts per million. But if it's not labeled gluten-free, so you're in the grocery store and the national brand of a food product is labeled gluten-free, but the store brand is less expensive, it's on sale, and you have a coupon, do you have to pay more because it says gluten-free? And not necessarily. So when we're looking at FDA regulated food, there are just those 6 words you need to look for on a label that would indicate the presence of gluten. We talked about wheat. And again, remember, wheat is going to be called out. It's not hidden. It would be called out if it were in modified food starch or dextrin or natural flavoring or any of those big words we can't pronounce and got numbers after them. If they have wheat in it, it will say wheat. Now, that's the only gluten-containing grain right now that has to be identified that way. If you don't see wheat, then we need to look for barley and rye. So barley has 2 other products that are made from barley, and a big one is malt. Malt is widely used in processed foods. It's in Rice Krispies and Rice Krispie treats and Kellogg's Corn Flakes and Lindt chocolate and Milky Way candy bars. So malt is something that's widely used in our processed foods. So it's made from barley. We need to stay away from it. Secondly, brewer's yeast is also a byproduct of beer production. The spent yeast could be used as a flavoring agent. It's not very common, but it can be in some foods not labeled gluten-free. So we have wheat, barley, rye, and at last, if it's not labeled gluten-free, we need to stay away from anything with oats. Oats should be specially processed or grown to remove the contamination from wheat and barley. So oats that aren't carefully sorted or grown have a high potential of contamination. So wheat, rye, barley, oats, malt, and brewer's yeast are the key words that we're going to look for on FDA regulated foods. A small little glitch comes with USDA foods. And these are foods that are governed by the USDA and usually involve processed meats and eggs, some canned soups. And there's a little symbol there that would indicate if it's a USDA regulated food. They do not have to follow FALPA, but 80 to 90% will voluntarily follow those guidelines. So if you don't see those or you're suspicious about what's in there, if they use dextrin, modified food starch, or starch, those could be an indicator that there's gluten in those products. But again, for the vast majority, we'll see the contain statement if they do have that. So the next slide. So here's another confusing piece of information that we get on the food label. So after we look and we don't see any gluten-containing ingredient, there's no wheat under the contain statement, but there's a statement manufactured in a plant that contains wheat, manufactured equipment that contains wheat, or may contain wheat. These are allergen advisory statements. They're completely voluntary, and it's used for the potential unintended presence of a food allergen. So in the case of oats, for example, so wheat is not intended to be there, but in the processing, the growing, the milling, etc., there could be wheat in the product. So this is for unintentional. Now, it's not well defined or regulated by the FDA. It does not replace good manufacturing practices. And if the product is labeled gluten-free, it still must meet the standards of the FDA rule for gluten-free, so meaning less than 20 parts per million. So there really isn't any reliable way. So again, remember that if you pick up one brand and it says manufactured in a plant that contains wheat, you put it back, you pick up brand B, it doesn't say that. It doesn't mean that brand B wasn't manufactured in a plant that contains wheat, they just chose not to put it on the label. Next slide. And actually a good friend from Tricia Thompson actually took a look at this, and she took a look through her program, her website, theglutenfreewatchdog.com, which I highly recommend. So she actually took a look at what the levels were. So she looked at products that were not labeled gluten-free, but some had the statement and some did not. So again, they didn't have any of these wheat, rye, barley, oats, or anything like that in them. But so she took a look at 101 products. And if we look over, 5 of those products tested above the 20 parts per million. Now, of the ones that contain the allergen advisory statement, only 1 of the 13 that she tested was greater than the 20 parts per million. Of the 87 that remained that were with no allergen advisory statement, 4 of them were greater than the 20 parts per million. So in conclusion, it's really not a reliable way to judge whether a product is contaminated or not contaminated. So if you use a product frequently and you're concerned about it, then you can contact the manufacturer if that's a concern. But in general, these are just not really helpful statements. Now, if you had an anaphylactic reaction to peanut, I would heed these warnings. There is no safe amount for a peanut allergy. But remember, this is not an allergy. This is an autoimmune disease to which we do know that there is a safe amount. Next slide, please. And again, to confuse things a little bit more, a new pizza is on the market, and this new gluten-free pizza actually uses wheat starch. So under the FDA rule, wheat starch is allowed, but if you pick up this pizza box and turn it over, you are going to see contains wheat under that contains statement. So again, that's confusing. However, it should have an asterisk followed by another asterisk to say that the wheat starch has been processed to allow this food to meet the FDA requirements for gluten-free food. So there are more products available that use wheat starch. Perhaps with the success or not of this particular pizza, maybe more manufacturers will start to use it. But it is acceptable because they have processed the wheat to remove the protein, and what's left is the carbohydrate.
10 minutes, Pam, 10 minutes.
Whoa. All right, next slide.
Sorry, I was looking at
Okay. Look up over there.
Sorry, no, I was looking at some of my notes there. So to be able to label your product gluten-free, it must be less than 20 parts per million of gluten. So in theory, the food I eat daily can easily contain gluten, but less than 20 parts per million. So can my blood antibody tests ever be 0? Okay,
next slide. Again, the whole 20 parts per million is very confusing to most people, what that means and how to interpret that. What we do know is most studies have shown that the vast majority of people with celiac disease can tolerate a daily exposure of 10 milligrams. And at this level, we do not see damage to the intestine. So we agree that 10 milligrams per day of gluten would be safe for the vast majority. So the problem is, how do we distribute those 10 milligrams? So how do we know when we're reaching that volume, or if we've exceeded that 10 milligrams? So how do we sprinkle that out through the day? So the parts per million of gluten, again, remember, is a proportion. So it tells you how many parts out of a million are made up of this contaminant. So it's really a math problem here. So again, 2 parts per million is equivalent of 2 milligrams per kilo. Breaking it down further. So if 1 ounce of food, which is just under 30 grams, contains 20 parts per million, then that would contain 0.57 milligrams of gluten. So in order for you to exceed your daily dose of 10 milligrams, you would have to eat almost 1 pound of gluten-free food, so breads, pastas, cereals, etc. So if you ate a pound of gluten-free foods at 20 parts per million, you would not exceed that safe level. And keep in mind, manufacturers are not shooting for 20 parts per million. They're actually shooting for 5 or as low as they can get them. So again, yes, you can get your levels back down. You can get them to normal if we stay under that 10 milligrams. Okay, next slide.
Do you find that skincare, makeup, bath products are truly high risk for gluten exposure? I know the answer to this question. Enough exposure to cause GI distress, elevated TTG, and Pam, while you're there, someone also asked this about kissing. Do you get exposed to gluten if you drink or kiss someone that has eaten gluten? So talk about people's love life. Help them out.
All right, the next slide, please. Fortunately, the gluten protein is too large to be absorbed through the skin. So things like, and I tease my kids and I say, well, do you sing in the shower? If you sing in the shower and you get shampoo in your mouth and you ingest it, then it's a problem. But it's not absorbed through the skin. So the cosmetics, sunscreens, lotions, like I said, shampoos, those are all fine. Parents ask me, can my child feed the dog? Should the dog food be gluten-free? And I ask if their children are eating the dog food. So it has to be ingested for it to be a problem. So, and again, things like toothpaste and other products that you apply to your lips. So lipstick, again, my friend Trish, again, gluten-free dietitian and gluten-free watchdog, actually did the math. So she broke it down as if you would eat 3 tubes of lipstick, or again, if you physically ate them. So the proportions of the lipstick, even, and again, she didn't have exact numbers of the tube of lipstick, if maybe it was 5% or 1% gluten protein, you would still be getting such a minimal amount that it's not going to be causing damage. So again, for kissing or touching, so again, keep in mind, this isn't an allergy. And as I said before, for peanuts, and I know people have heard with an allergic reaction, children eating a peanut butter sandwich and then kissing a boyfriend or whatever, and then having anaphylactic reaction. We do have a known safe quantity, and that quantity, that amount that you're going to get through kissing, is not going to cause a reaction. Now, if you have a teenager and you want to prevent dating and all that kind of stuff, we can always parents are allowed to throw that one in there as well.
4 minutes, Pam. 4 minutes.
All right, next question.
Okay, I am looking for a good dietitian that understands celiac disease. How do I find one that is close to where I live and not in Maryland?
Next slide. So here is my plea. Please, 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 please stay off of Facebook pages, face group that are just specifically for people that post about their celiac disease. Unfortunately, I have to talk many parents off the ledge as they listen to the information that they're finding on websites and support groups and mommy groups and this type of thing. I had one family that actually, every time they went on vacation, they stopped at Walmart. They bought all new pots and pans because they didn't want to take them to the house that they were renting because they thought they had to have new everything. You hear anecdotal stories about, my son walked by a bakery and he, almost died because he inhaled something from the bakery. So there's too much misinformation. So here is a list of really good places to go to look for information. Now, specifically for a dietitian, you can go to the Academy of Nutrition and Dietetics website, eatright.org. You'll find a space to search for a dietitian. They will tell you, it'll ask you what state, it'll ask you what what you want the dietitian to specialize in, and help you. Also, if you contact some of the organizations like NCA, they have many dietitians that work with them, and maybe they can help refer you to a dietitian in your area. They also have a lot of great information posted by dietitians. So for general information, gikids.org, again, is an ASPIGAN site that has a brochure for information. The Celiac Disease Foundation, and this is a shout out to all the dietitians who may be listening to this, that the Academy does have a certificate of training that has been developed. It's 5 modules, so you get 10 continuing education credits. And the Celiac Disease Foundation will actually reimburse you for the cost of taking that. So for dietitians who want to learn more and want to feel more educated about celiac disease, please check into taking the certificate of training. And do I have time for another one?
Yes, you have 4 minutes.
Oh, wow. Okay. So next slide. Okay.
Yeah, you have 2 minutes, Pam.
Wait.
What are the most this is important. What are the most significant nutritional deficiencies caused by celiac disease and gluten-free diet? How best to address these deficiencies?
Okay, next slide. So again, the gluten-free diet can be missing some important nutrients. Keep in mind that our processed wheat foods are fortified and enriched. They're fortified with B vitamins, iron, and folate. The gluten-free products may not be fortified or enriched. So that category of the B vitamins, folate, iron could be low without the additional support of the supplementation. Because you're using more starches and gums, it could lack the fiber. So there are important things that it could be missing. So the next slide, we talk about ways to improve it. And really, the recommendations here are no different from recommendations that the dietary guidelines are making for the vast majority of Americans, that we should be eating better. And we should be including all those great naturally gluten-free foods, such as your fruits and vegetables, labeled gluten-free whole grains, your amaranth, your quinoa, teff, buckwheat. Those are excellent sources of nutrition. Even the gluten-free oats added to the diet boost those nutritional values. So using those whole grains. Your dairy products, again, for your calcium and vitamin D, heart healthy fats. So looking at the overall diet, still kind of looking at the Mediterranean diet, which has always been hailed as one of the best diets to follow, will help you really round out that diet. But also in the beginning, you may want to take a multivitamin. You can discuss this with your physician, dietitian. If you have damage, you may not be absorbing the way you should. So a multivitamin may be necessary, especially vitamin D. I think just about everybody is low in vitamin D because we never see that big ball of fire in the sky very much. So vitamin D is important, and how long you've been undiagnosed, how long have you gone without absorbing vitamin D and calcium. So sometimes those supplementations are necessary. And by the way, vitamins and supplements are covered under the food labeling law. They're not a medication, they're food. So the food labeling law would cover those. So be sure that they're not containing any wheat products. I don't know if we have time for the last question.
Melinda? Okay. What do you recommend to help with accidental glutening? Do you recommend any supplements such as L-glutamine or others that suggest they can aid with gluten digestion?
Okay, so the next slide. Again, this is something that I'm hoping my fellow panelists will chime in with. And I'm glad that Mark pointed out earlier that you will get contaminated. My tagline is we live in a world of wheat and we live with human beings. So it's a very bad combination for somebody with celiac disease. So you will get contaminated. So going forward, and as Mark pointed out, it doesn't mean total villus atrophy. But it may mean some very uncomfortable symptoms. Unfortunately, there's not really a lot that we can do. So, again, it just has to kind of work its way through. You can treat, headaches or with, some over-the-counter medications. Sometimes ginger will help with upset stomach, fluids, rest. We don't really recommend L-glutamine. I don't think there's any great research to show that in celiac disease, specifically celiac disease, that it's of any help. So again, I don't know. Does anybody else have any other added comments to what you do if you've been glutened?
I can chime in. And so, I totally agree, Pam, with what you shared. It's really, supportive measures. And, I guess the light at the end of the tunnel is that if it's really an unintentional gluten exposure, the symptoms should abate over time. The perspective I would like to add that I often also add when I speak to my families about this question that often is raised is, sometimes it's hard to really discern whether or not your symptoms are due to gluten exposure or if it's due to something else, yes. Whether it's a sick contact or something else, and so
yes.
I'd sort of add that piece. And oftentimes it's hard to say, but in terms of the gluten exposure related symptoms, generally supportive measures, as you mentioned, and should get better after a couple of hours or over a day.
I do say that you can have symptoms with no gluten and you can have gluten with no symptoms. So symptoms are not necessarily an indication that you have been exposed. So you're absolutely right. So it may or may not be to a gluten exposure.
And I would just add one more point. If it's determined that most likely the exposure was gluten related, and let's say a patient has just ongoing diarrhea, so gluten reaction, I completely agree with these conservative measures that you recommended. But there is also a role potentially for a short trial of a steroid like budesonide to help if there's inflammation that's causing the
very serious. Right.
Yes, and often I'll also it's a supportive measure too, but if someone predominantly has nausea, vomiting, and some kids can be sick for a day or even longer, I'll give them a prescription of Zofran, which often really helps them.
Thank you very much. We are just floored by the great questions we've gotten. So we received. So we will take a look at those as we plan February through May 2022, and we'll pass it back now to Lee. Thank you so much to our amazing speakers and our amazing moderator. Lee?
Thank you. I agree. I really appreciate all the wonderful ideas that you've shared with us. I feel like I've learned so much. But stay tuned for our February to May 2022 webinars addressing things like pregnancy and celiac disease, food insecurity in our community, and managing the gluten-free diet in long-term or assisted living programs, and then much more. So until then, happy holidays and have a very happy and healthy new year.